Pneumonia. First one, I want to talk about there are two types of pneumonia in the clinical setting. So we usually call it a typical versus atypical pneumonia. Typical pneumonia usually presented with high fevers, chills, cough, productive cough. The atypical pneumonia presented with more extrapulmonary symptoms like fatigue, abdominal pain, nausea, diarrhea versus cough or chest pain. Then you will hear terms like community-acquired pneumonia, healthcare associated pneumonia, and nosocomial pneumonia. Those are the same as healthcare associated pneumonia. However, there are two subtypes under healthcare associated pneumonia. Can be hospital acquired pneumonia or ventilator associated pneumonia. You will see the terms they use basically direct their treatment because they normally associate with a certain type or group of the bacteria in that category. So pathogens, as we described, if it's upper respiratory infection, most of them are virus. But if it's lower respiratory infection, only 20% caused by virus and 80% caused by bacteria. And the Streptococcus pneumoniae is still the number one cause of community-acquired pneumonia. We call it typical pneumonia. Mycoplasma pneumoniae, Haemophilus influenza, Chlamydia pneumoniae, Legionnaires species cause pneumonia. They're all grouped in the atypical pneumonia. Other bacteria cause pneumonia like MRSA, MSSA, or Pseudomonas, more likely in a hospital setting or patient in ICU. And this further described where the bacteria usually distributed based on the site of the care. You will hear a lot of time we cannot wait to hear the culture results, like a sputum culture, blood culture. So we will give antibiotics. However, we already reviewed that what kind of bacteria more likely will be the cause of this pneumonia. Then you will prescribe that. You will see the antibiotics prescribed for empirical treatment purpose. And if the patient just have a cough, for example, slight fever, cough for almost a week, and have not yet improved using cough medication, and the cough is gradually getting worse, and cough associated chest pain, they have fevers. In this time you think if a patient have not yet have a sick contact or have no prior hospitalization or antibiotics in 3 months, then you can just see them treated with micronide. The most common micronide these days we use is azithromycin, and you will see doxycycline will be the alternatives. Let's say that a patient have a comorbidity like like COPD, asthma, coronary artery disease, CAD, and this is the time you will see that they started with antibiotics, has more strength, like respiratory fluoroquinolone. The most commonly prescribed medicine is Nevoquin or levofloxacin. Alternative first-line treatment will be beta-lactam. You will see more like cifotraxin plus micronide, as we said, is azithromycin. Usually you see them getting treatment for 3 to 7 days. When the culture is coming back, most of the time you will see that the culture result consistent with the antibiotics already been chosen, simply because we know more likely what kind of bacteria is in that setting. Treatment plan should be modified if the culture came back differently from what we anticipated. We talked about community acquired pneumonia. Here is the healthcare associated pneumonia. More likely in healthcare associated pneumonia caused by gram-negative bacilli and the Staphylococcus aureus. And here you need to give a broader spectrum antibiotics coverage. And the number one used is vancomycin plus piperacillin tazobactam, which is Zosyn. Vanco is covering 4 gram positive, and the Zosyn covering 4 gram negative. And you can use vancomycin plus meropenem, which for patient is allergic to penicillin. And you can use Zyvox in place of vancomycin plus cefepime. Cefepime is antibiotics covering 4 gram negative bacteria. In addition to antibiotics for pneumonia patient, we should maintain the oxygen saturation greater than 90%. If you see the oxygen saturation is less than 90, you should ask a patient take some deep breath, increase the oxygenation by giving supplement to oxygen. You also need to monitor patient dyspnea, and the dyspnea is related to hypoxia, chest pain, not able to take a deep breath, things like that. Also monitor patients' cough. Cough should be encouraged, because if sputum is not coughed up, they tend to be staying inside the alveoli, therefore will impel the gas exchange, and the bacteria can stay there longer. So you can give some cough medicine like guanfacine or Tasolone. However, it is not recommended to give a cough suppressant. We also need to monitor patient to develop a severe sepsis or ARDS due to antibiotics cannot control the infectious process. Early ambulation has been proven to reduce length of stay in hospitalized pneumonia patient, and the chest physical therapy such as deep breathing, cough also can increase the pneumonia um,